told
Hi, good afternoon. Good afternoon, everyone. Very fortunate and humbled to be here in front of all of you, and thanks for taking the time and joining us and talking about this topic that has been on the forefront of a lot of stakeholders, payers, providers, pharma, retail pharmacy, digital transformation, Internet of Things, digital revolution, and that. But I'm here with this panel. Take a minute just to kind of introduce yourselves, and we can start talking and addressing some of these complex challenges that we're facing. Tom?
I'm Tom Lundquist. I'm the Chief Medical Officer, Senior Vice President at Optima Health, which is a fully owned health plan of Centera Healthcare. And certainly well in the thick, as many of you are, on digital transformation, patient-focused analytics, as well as patient-focused digital tools for the home space, as well as the provider space.
Hi, my name is Bhaskar Balu. I'm the Vice President of Enterprise Information for the BlueCross BlueShield Association. My role is primarily in kind of looking at data initiatives and championing some of those initiatives for the Blues, both in kind of some of the foundational capabilities as well as some of the emerging innovative areas, the big data and some of those collateral technologies.
Hi, my name is Ian Gordon. I lead the operations for Regence across all 4 of their states. I unfortunately have a chronic illness. I like this healthcare space, and I've been in it for a really long time, so I'm pleased to have the opportunity to try and help think of ways to make it better with all of you.
Hi, my name is Scott Haas. I'm Vice President of the IT Payer Services Division, which is of UPMC. UPMC is an integrated delivery and finance system in Western PA, and my responsibilities are really for the entire technology footprint for the insurance services component of UPMC, but also working across and with the provider side, both at UPMC and our non-UPMC network.
Great, thanks. It's we have a diverse panel here, integrated delivery networks, the Blues Association, what they're seeing overarching there, and health plans that are really pushing the needle like Cambia is and Optima. What we want to talk about a little bit, what we're hearing at the AHIP Innovation Lab in Chicago, where our members are coming in one-on-one, is really there's a lot of noise out in the marketplace, a lot of different directions that we can go into. What is the process to really cut through that noise, making sure that it fits whatever the innovation that we're trying to operationalize? How does that fit into the overall strategy? Does that strategy incorporate other stakeholders in your market? And really going through that process is a significant lift, but with a lot of options that are out there. Maybe we can start off with Ian talking about what Cambia is doing in terms of sourcing innovation, operationalizing that, and what's the process to kind of make sure we're on point.
So we absolutely recognize the need to collaborate across the marketplace. And as we look at our 4 states, we're constantly looking for opportunities for the payer, us, and the provider marketplace to come together. We've done all the traditional things that everybody's done. We're looking at value-based reimbursement and trying to balance the risk and those types of things. But we're really trying to find the right providers to look at how do we view the individual consumer, trying not to use the words member or patient, but basically the consumer, and how do we come together to create a model that empowers the consumer to work across. And we recognize that the interplay between us and the provider community is absolutely critical, which is then obviously driving the need for us to exchange information and to find interoperability between the platforms that we're both trying to use. And I'd lie if I said it was anything but challenging.
That's great. Scott, talking about being in an integrated delivery network, the platforms that you're using, a lot of people will think that it's fairly easier because it's the payer and plan under one roof. Some of the challenges in the digital revolution going on, the Internet of Things that are taking place at UPMC, are you seeing a lot of more cohesive partnership?
So UPMC is a pretty complex and big, very large company, and basically we do have, I think, the benefit of having a growing and fairly significant payer side, as well as a very large and somewhat dominant in the region, at least in the Western PA region, a provider side. That said, there's, I believe it's 5 EMR systems that we have and maintain. We have, obviously, on the provider side, on the payer side, we have a population health system that is integrated in some capacity with those EMRs, but not nearly as fully as you would want to be. And as we talked prior to, I think, we have several different initiatives going on from different areas and different components of the UPMC enterprise, both on the home health side, on the provider and the ambulatory side, as well as on the payer side, focusing on areas like remote monitoring, focusing on wearable integration. So really the full gamut of wellness prevention all the way through chronic conditions. So there's a lot of people thinking about and a lot of projects and initiatives, I think, trying to address how we can better leverage and how we can work together both within that network, and obviously on the health plan side, we're not a closed network like Kaiser as an example. So we have we have the UPMC physicians, and then we have the non-UPMC physicians and providers that we're also teaming with. So I think that we have a lot of energy towards this space, and how can we best provide both population level solutions and solutions that help down to the individual consumers. But tying those strategies all together is a large and unwieldy beast within UPMC, let alone when we try to look at how we're interacting with our other provider entities and partners.
Yeah, and other stakeholders in the market too, which is another one. A lot of projects, a lot of initiatives going on. Tom, maybe we could talk a little bit about how you're going through the challenge and problem stratification within the organization, and how you're going to be putting and continue to add digital tools and enterprise solutions to the challenges, and how do you kind of prioritize them as 1, 2, and 3?
Sure. So I think to lay the context real quick, Sentara Health System, 13 hospitals. We've got about 800 employed physicians, part of Sentara Medical Group, and then around Sentara Medical Group, we've got what we call Sentara Quality Care Network, which is about 2,400 physicians that are affiliated now through this clinically integrated network. And then the health plan, of course, we've got a lot of our members who go through the Sentara system through Sequin. We're launching, as we speak, a value-based contract for about 20% of our members that are attributed to Sequin. But then, a lot of our members, including those that go through Sequin, don't go through Sentara facilities, right? So Sequin and Optima represent lives that are outside. So with that context, there's a couple key fronts that we're focused on. One, being a highly matrixed organization, when I landed there 2.5 years ago as the Chief Medical Officer for the health plan, I was asked to co-lead care coordination across the continuum for Sentara's system. So it's kind of an interesting place for the health plan CMO to sit. But I'm now partnered with the Chief Nursing Officer, and we look at this. And as we think about care coordination tools, we're an Epic shop at Sentara as an enterprise. And Epic has an evolving story that sounds very good around what they think they can do for care coordination across the continuum beyond just Epic users. So for Sequin, where a lot of our physicians don't have Epic, Epic seems to say they have a solution that's forthcoming. That stated, I have brought with me a partner and a vendor that I've been working with as I went through Tennessee with the Blues, doing value-based payment, population health management with providers through an ACO, and then landing at Sentara. Another vendor that sort of wraps around that space and has a high level of efficiency. So to me, critical is how do we help providers, we as a health plan, help providers, one, be successful under value-based contracts, right? We are committed to making sure that they make money and do it well. And in order to do that, we believe we have to help with care coordination tools and new platforms for them to utilize if they want to. We're not going to force it upon them, but things that will work within their workflow as a practice that will help them be more effective and efficient at not only gaining money under value-based contracting, but also potentially capturing some of the new revenue sources. So these systems can be built to help them capture some of the new chronic care codes, for example. And then you throw on top of that then the need to look at the 1,000 shiny things that are all in front of every one of us, right? The smart monitors for diabetes, and the 16 companies, some of them represented here, that are doing chronic care management in the pulmonary space, and then another 30 that are doing it in the diabetes space, and 30 is probably an understatement. So as you start to look at those, how do you start to be selective at choosing some of those tools? We don't do that in a vacuum. Being part of a provider organization, we have to have clinicians take a look at that with us. I often invite, once I do a quick vetting, I'll invite some of the clinical leaders to listen in as well and say, what do you think? And if they say, boy, this would be a big help for us to manage patients better, not just for Optima, but potentially for multiple sources, payer sources, or it would help us have those patients connected to us, whatever the reason. If they're excited about it, then we look at building a pilot. And we try to get, we're big on pilots, and then the question in the back of my mind is, well, as we're building the pilot is, how will this scale? If we do, in fact, prove that return on investment, and we improve the clinical decision-making and the patient's engagement, then how will we scale it up? So
that's great.
Long answer to your question.
No, it's very, very comprehensive. Bhaskar, I want to talk, you have a great view into the Blues plans and seeing what's being sourced and how they're being connected. These solutions are generating a lot of data. How are you seeing some of the Blues plans take from the digital tools that are out there, take that data and share it within their organization and then through the ecosystem to make it actionable? Because we're not collecting information just for the sake of collecting it. We really want to kind of drive toward those outcomes, especially in value-based. So maybe you should talk a little bit about your experience there.
Sure. I'll start with a pet peeve about mine related to healthcare in general. We suck big time at the basic foundational elements in the data space. We don't do provider well. We do membership eligibility really bad. I mean, those are kind of the basics of healthcare. And we struggle with it on a day-to-day basis. And in this increasingly fragmented, interdependent world, what we really see is an ability to kind of get those two right. Because if you're trying to create or integrate with some of these disruptive technologies which are out there, so we talk about wearables, that's the buzzword out there nowadays. How do I integrate that with the member information I have? Or the care management system which is capturing data from another place. How do I integrate all that information together? That weaving together of all that information, you may need a master patient identifier, but that technology doesn't give you 100% accuracy. It gives you some level of, there is still some gaps in there. And those are things which I think are fundamental, and those are some of the basic challenges we are trying to at least address within the Blue system. So what we try to do is we are creating this master patient identifier, a very highly accurate identifier. Similarly, on the provider side, we want to actually capture that information accurately as well. Because it's kind of strange that we have some plans who are not able to even articulate if a provider is accepting new patients, right? That flag, that indicator which they have is wrong quite a lot. And they're getting fined by CMS for it. So we have those foundational challenges, right? So can we just stop everything and just fix those? No, we can't. We have to kind of really move the needle in the innovation space and figure out how are these technologies coming in, how can we kind of accommodate as we go along and in this journey, which we don't quite know where that destination is. It's just going to be increasingly complex is kind of how we see it. That increasingly complex world also leads us to this notion that we probably cannot be that single source of truth for everything. So we are looking at all options as more in a federated space where we may have to have some data which we own, maybe claims data, provider data, some other data, but there may be some other data which we may not need to actually keep within our premises. We may just suck into that data and tap into the relevant pieces of it and stitch that together in real time when we are kind of providing those capabilities back to a consumer. So you have a lot of technologies today which are in place. Siri, for example, on your iPhone, or Cortana, which Microsoft is kind of pushing. So they have the horsepower to kind of pull together different sources of information, put together information back to you in a very interactive, rich fashion. And the data which fuels that, right, can be data which comes from plans. It could be data which comes from providers. It could be data which comes from DME vendors. It could be data which is being tapped into real time from the person, the member himself, right? So if you're kind of, if your Fitbit is analyzing your sleep patterns, it can kind of take a look at that information, digest that, and provide you some feedback in real time saying, you know what, you probably need 7 hours of sleep. You're only getting 6 hours of sleep every night. And it can actually enrich that experience with you and provide you maybe reminders at 10 o'clock and say, you know what, you probably need to sleep now, right? So we see some of those things happening, and what we're trying to do is we are not trying to solve everything. We're trying to make sure that we enable the relevant data and provide these niche individual products which can enrich that individual consumer experience in places where we can potentially add value to the overall system. So that is more on the consumer side, but even within the health plan side, there are plans who are looking at prior authorization as a place where they can kind of tap into the sensor data which is captured from, let's say, the sleep, the CPAP and APAP devices for people who have sleep apnea. That data is nowadays captured wirelessly behind the scenes. And you can actually tap into that data and really cut back on fraud, waste, and abuse, especially when the supplies are sent back periodically every 3 months. You can actually tap into that data, figure out if somebody has actually been using that, and cut back on some of those. So there are various ways in which you can actually deploy these solutions in small areas and get some incremental returns on investment, because we want to keep moving the needle forward. Probably the new world out there may be radically different than where we are today, but we cannot stop moving.
That's great. It was about 21 minutes in before we heard the word CMS in this panel. That does a lot of uncertainty in the last 6 years, the passage of the ACA. Ian, can you talk a little bit about pushing the innovation, the digital revolution, transformation that's taking place, but still operating in a very highly regulated, changing environment? I know you guys have done some great things from beginning to end, but it would be very beneficial if you could kind of share those examples.
Sure. So I think one of the challenges there is understanding what our role is. I think all the players in the industry struggle to truly define a role, and as you look at the payer side of things, we've got to figure out what are our core competencies, what should we focus on, what differentiates us in the marketplace, and ultimately who's the customer. And so what we've done is we have spent our time really focusing now on the consumer. Our challenge is we have this legacy company that we're continuing to run, and we need to make the investments in that company to keep it running. That's where all the membership comes from as we look at the other opportunities that exist. So there's a real balance there, but as we make investments, it's really to try and focus on what can we do for the consumer, how can we connect to the consumer. I think we recognize and believe very much so, with Mark Gantz, as our driver, that we are in a consumer business, and that ultimately, even though a lot of our membership comes from groups today, over time we'll continue to see the individual consumer having a greater opportunity to make decisions. We're trying to figure out what can we provide to that consumer from an information perspective that allows them to make decisions. So whether we're looking at transparency, for example, there's one of our Cambia companies here, Spendwell, looking at how can we have the consumer be in a position where they can actually choose the provider and control the cost, having a cost transparency tool. We're looking at how can we provide them with their information about their health care. And that's one of the challenges that you raised, is that we don't own it all. We don't have access to it. And so as we try and take things like sleep information and use that data we don't have a huge portion of that consumer's life. And so the direction that we're providing is somewhat a slice of their world. So part of what we're trying to do is then partner. We don't have an integrated model like some folks, so we're trying to figure out how do we partner better with the providers to say, okay, we'll do this piece. You can manage the population, manage the care, manage the consumer. we have the ability to provide this type of information, these type of tools, and pull that together. So I think that's, at its very core, it's about the consumer for us and looking at what types of solutions can we provide, because we need to, and they're buzzwords, but we need to meet the consumer where they want to be met. We can't keep asking them to call us between 8 a.m. and 5 p.m. Pacific time, and we'll take care of everything there as long as you have your ID and that type of information. So it's a challenge for us to migrate, I think, in its very core, to being a legacy environment, having to do all the things we have to do in a highly regulated environment with kludgy systems that we have to figure out how to untangle, and to morph into a digital consumer company at the same time.
And that's the goal that Cambia has stayed the course for a very long time, and with leadership like Gantz, it's great to see it supported, the culture's there. You said we need to meet them where they are, right? That's the buzzword that's been there for a while. We also need to meet them in a way that's going to resonate with them to drive action. And in order to understand that, we have to be able to ask them. So UPMC, I know, operates as an integrated delivery network. There's some others that are out there, and other health systems that haven't been very kind of patient-centric or consumer-focused. If you talk a little bit about how UPMC is really trying to get the pulse of the consumers, sure. And do we tap into these emerging companies and startups that have kind of that pulse to get the data of what's important to the consumer, or do we go out and try to do it ourselves?
Yes, that's a really good question. I think at UPMC we have over 60,000 employees. We have over 20 hospitals. We have 2.9 million members. And we have the affiliation with the University of Pittsburgh. So we like to refer to our situation actually as like a living laboratory. Sure. So I think one of the advantages we have is we have the ability to test out a lot of these different strategies, tools, and approaches with those populations or small populations or subpopulations within our own environment, because you have patients who are members, who are providers, who are employees, right? So because of those dynamics, we're actually able to, I think, to look at things in a little bit different manner and test things out, and then if they work in small doses, then we can look at and see, and obviously the scalability of those is a big question and challenge. So UPMC looks at both on the health plan side and on the provider side. They look at those things both individually and together in that capacity. The other thing that we do is that there's an arm of UPMC called UPMC Enterprises, which is actually a commercially focused arm. And what they do is they look at technologies that can both help UPMC and potentially could be commercially viable for others as well. They do both an external view of that world, and they also look at UPMC's assets and say, are there things we're doing on the payer side or the provider side or technologies or business models that we could actually take, leverage, and push out to others, and if so, why? So I think that those factors really weigh into it, and they give us probably a good head start on some of those challenges. That said, those challenges are still pretty daunting, and I think ultimately in the world that we're all living in here, I think sitting up in this panel and the audience is regardless of how closed your system and environment is, you still only have a portion of what that consumer is looking at, right? What they're experiencing day to day. So I think ultimately we have to come to the grips with there have to be some level of standards, some level of sharing of both the data and or the tools or the methods.
Yeah. Great. Bhaskar, as the Association for the Blues, could that be a role that you're playing in terms of Internet of Things and all these disparate technologies of kind of pulling that together and then sharing them, but making sure that when you do, it's at the time of need and addresses for that stakeholder? So if it's retail pharmacy or the consumer, it's a big task, a big ask, and a lot of the companies are doing that. There's that willingness to want to be able to connect the stakeholders throughout the ecosystem, but then could you really see being the aggregator in this transformation period in healthcare, the payer could really be that information holder and then helping them make those decisions, whoever the stakeholder is?
So, in the payer space, we actually have quite a few challenges, primarily on what we can and cannot do with the data we have. That actually is a huge impedance to what my specific role is. My role is to democratize and make data available more freely, while at the same time making sure it's being done in a very cautious and secure way. We are not running afoul of any antitrust issues or any HIPAA kind of concerns. There's a huge aspect to that within the US, which is somewhat kind of archaic. Europe is a little better or further advanced on the privacy side of things. Within the US, those controls are not quite there yet in terms of what we can and cannot do. That constrains us quite a bit. Now, in terms of making the data available, yes, we want to do that. But when we start doing that, we have to do it in a way where you constrain that information. So I can make data available in a de-identified fashion. But if I do that, what happens then? The value of the data diminishes quite a bit. And therein lies quite a bit of the conundrum is as we start creating some of these solutions. So I talked a little bit about that Siri solution, right? Where you're talking to your personal digital assistant and it is actually kind of interacting with you. Take that experience a little further. So let's say that digital assistant is interacting with you, tapping into all these disparate sources of data, and then it can actually tap into figuring out whether you're feeling sick. If you're feeling sick, you can interact with it, and that next level of handoff can be actually to some kind of a teledoc facility or some nurse practitioner or somebody who can then triage it over to a teledoc facility, a telehealth solution. So these are disruptive solutions which are out there, and we don't quite know exactly what the regulatory frameworks surrounding those are. It's almost like Uber, where a lot of the legacy taxi companies essentially were blindsided by it. So some of these things are happening. So in the healthcare space, obviously it's a lot more regulated, but I think what we are kind of looking at is the pushing and fraying of those boundaries and kind of the changing of that external dynamic, which is forcing us to evolve our situation and our position in the marketplace.
Sure. So you talk about the marketplace. There's a lot of solutions that are out there, and there's an industry for wearables, for example, but there hasn't necessarily been an adoption of a market for the wearables and a lot of these digital health solutions that are out there that can help really manage care. What are some of the things that you're looking at? We can extract data from anywhere. We can capture data from the consumer and from other enterprises. But really for the three payers and health systems here, the question is, what is it that you're looking to get from these digital revolution tools and these transformational tools that are out there that's really going to impact what you're doing today, but also where we're going to be in 5 years from now, 10 years from now, as we become organizations of health and well-being? Are there 2 or 3 data sets that you normalize that would be helpful as we're partnering to build out these digital revolution tools? Tom?
Yeah, I think that there's so much basic blocking and tackling we still have to cover, right? So it's really easy to get distracted by this sort of future world that we certainly have a vision for. But there's blocking and tackling. So for example, colorectal screening, right? Not that sexy, but very practical. And when you take a health system that owns a health plan, it's actually a safe space for us to play in. If we can get colorectal screening up, right, even if we do it through some of the new testing methodologies that decreases colonoscopies, we're still going to generate a number of positives that still require colonoscopy, so it continues to feed the health system while increasing the overall rates, right? So that's a win-win-win all the way around. And as a health plan, we're identifying people earlier, so it's good. So that's one example. Diabetes space, I think the biggest challenge we have is trying to figure out what the patient, and this was mentioned earlier, what the patient really wants. What's their consumer preference, right? And I think if there's a holy grail that I'm looking for in the next year or two, it's how do I incorporate certain consumer data, retail data into our decision-making process so that we know that Tom Lundquist likes an email followed by some text messages, whereas somebody else wants to be be messaged on their smartphone, where somebody else wants a phone call the traditional way and wants a nurse to reach out to them. Getting that data into the data set so that as we build clinical pathways and we build clinical workflows, at the top of that list is this is how the patient wants to be contacted. I often go back and I often challenge physicians around the non-compliance issue, and I've been doing this for years. And a lot of people want to say there's 10, 15% non-compliance, maybe it's higher depending on the issue. And I contend, going back to my patient years, very few patients don't want to do what's necessary to be in better health. Yep. Right? If you really sit down and talk to them, there's a couple, and I can name them almost on one or two hands that I've interacted with over my years. What we do as a system of healthcare is we fail the patient, right? We don't give them what they need in the way they want it. So this whole idea of retail consumer data fed into the workflows, data capture, whether it's the health plan or somebody else that can feed it to me, and then I can build workflows around that. That to me is one of the holy grails that we've got to go after here in the very near future. And that will drive, more basic blocking and tackling. Right? Diabetes management, colorectal screening, breast cancer screening. These are not new issues. We just don't do it very well as an industry yet. And that's sort of one of the first things I think we've got to prove we can do. And what I'm seeing, so to kind of give some hope, is working in collaboration with our primary care collaborative, which is part of Sequin that I mentioned earlier. The providers have been trying to tackle this issue. And for example, this past year, partly because we incentivized the behavior, we wanted them to go after this, they were able to move not just process measures, but clinical outcome measures. They bumped diabetics with A1Cs less than 8 up 10 percentage points. Wow. That's huge. Yeah. Right? It's huge for my HEDIS measures, which is great for that, but better, it's great for the patients, right? So how did we do that? Well, we did it by introducing some new smart monitoring diabetes as one pilot. We did it by them just doing the old-fashioned outreach, call the patients who haven't been in the office in 6 months, right? They start to, so it was multifaceted, and it was using some data, it was using motivational scores for some of the outreach, and how do we get to people? So it's sort of kind of getting all that too. But at the end of the day, any information, if it's not built into a workflow and can't be standardized, it's of less value to me. So that to me is the holy grail.
Tom did a great job of outlining how it affected, and it was a win-win-win across different stakeholders in the ecosystem, the consumer, the provider, HEDIS measures, so it made financial sense, and we have to really look at that. I think we're in a new era now where we really have to build the business case, not only internally with to get buy-in, but also with external partners. Ian, some of the data that could help you do that and actually have an impact on the health outcome and the health status of plan members.
So I think that we focus a lot on a couple of modeling types of things. So propensity for consumers to do certain types of things, for them to purchase, for them to stay. We look at preferences, because I think it gets to that point about meeting them, how they want to be met, where they want to be met, with those types of things. And then trying to get insights from the data that we have. I mean, we have so much simple data that we fail to look at. One very simple example that people don't always look at is use of ambulance. If you look at the use of ambulance in certain populations, in certain areas, what you find is that you're running a taxi service. It is an amazingly expensive taxi service. So if you understand that by looking at your data and the population, putting it all together, you can actually drive up compliance because you can provide car service at a far less expensive rate than an ambulance is, which is used less frequently than, and you get people to be healthier. So understanding that, I think, is really important. So it's around propensity and preferences, and then just insights into that very basic data that you have today, which will tie them together. Tied to propensity is really the compliance. Is really what information and data do we have about compliance and how compliant people are being. And that's a real partnership with the provider community, because it's about coding, it's about the appropriate documentation, and having the 360 view of the consumer, not just the piece of their life that you ultimately know about. And if I went to the third piece, it comes down to, what about the healthy folks? What's important to them? We focus very much on the chronic. We focus on how do we get our risk scores appropriately documented, those types of things. But as we look at propensity models and preference models, as we look at this whole other piece of the population, is how do we help them see what we do as valuable? And that's really what starts to stretch your traditional payer far beyond being a traditional payer. It starts to say, what types of products and services do you need to offer? Because if you look at the life stages of an individual, there's a point where I have health insurance simply because it's mandated and I have to have it. And then as you work through your lifestyle, it becomes more and more important. Well, so we talk about ancillary types of products beyond, as a healthcare company, you talk about medical insurance as your primary product, and then everything else is ancillary. Well, if we're truly focused on consumers and what's important to them, then health insurance is an ancillary product at some point in their life, and ancillary products are actually the primary products. If we don't focus on the consumer, especially the healthy ones, we'll miss that, and that will put more and more pressure on your legacy health environments to try and be profitable and successful.
That's right. You mentioned what is it that we need to be, and then to the consumer, and then offer those up. You've thought about what that value creation is, and also where you want to be in the future. I think the last 10, 15 years or so has also been kind of health IT is going to be the savior. We're going to get the health IT, and then we're going to jump everything into that health IT, and it's going to get us to where we want to be. It's not working. And with the digital revolution, we don't want it to be, let's just dump it into apps and consumer tools, and then we'll take whatever we can get. The hope is that we're going to actually be able to structure and sketch out what the value is, and kind of engineer the value, and then have the digital revolution enable us to do that. Are you seeing some of those things in terms of whether it's through the enterprise at UPMC or with the consumer, where you're thinking it through with them first, or what you want to create, and then having that digital take you there?
I think I've heard a lot of great ideas and concepts up here, and things that have been worked on. I think when we talk about you talk about the digital revolution, you talk about consumers and what they want. I think what we really need to focus on, and what we're trying to do at UPMC is take the population health model, right, and the personalized health model, and tie those together. I mean, and that seems counterintuitive, right? Because one is at the person level, at that consumer level, and the other one is at those broad-based populations. I think when you take the data and the analytics that we have, not just at UPMC but across the board that everybody has, I think that there's a lot more there than you think. And one of the things that we're trying to do is to tie not only the clinical and the claims-based data that we have, but also take that household data. We go out and get household data, and then we try to understand the potentially and the propensity that those folks will have for certain types of care, as well as what is their preference. To Ian's point, one of the things we're trying to build out is a preference like center model that basically tracks, when we go out, when we communicate to Ian in certain ways, what does he react best to? Mm-hmm. And then we know the next time that we communicate something about his, a screen and a gap that he needs to close, that this is the modality that works most optimally with him. And then you basically take that model and you continue to refine that so that you waste less time and energy on and we're spending our dollar the most wise way and in the most targeted way for those consumers.
Yeah. Bhaskar, there's tools that are out there that are capturing a lot of the data, asking the consumers to kind of join in this revolution of health, Internet of Things, and then share it back with payers. Do you see, I know that when my members come to the lab and we start solutioning around it, the infrastructure isn't there to capture that data and then communicate it back to the consumer. So they're not getting rewarded for using the mobile applications and the digital tools that are out there. Have you seen some markets or some tools that are out there that can help us actually bring that infrastructure gap in the meantime while we're focusing on building out that new infrastructure toward value-based care?
So that's so true in a lot of ways. I mean, we are drowning in data. Information which you can gather or kind of create business value out of those they're few and far in between. So we actually are really looking for those great big ideas to kind of help us create some value. There are people who are kind of using this data in incremental ways, some a little more kind of transformative ways. So some people are actually trying to fill gaps in care by kind of looking at, let's say, EMR data and physician notes, and seeing if some of that data can help improve their HEDIS scores, for example. Easily achievable. Big data can kind of bridge some of those gaps pretty well. The challenge at the end of the day essentially is how do you kind of create a business model which allows you to kind of succeed in this space. And because there's so many ideas and so many different approaches out there, within the plans, we are kind of seeing a lot of different kind of drivers. There are some plans who are really into genomic data. They see that as the holy grail for the future because of all the new kind of the treatments which would be all based on some of the genomic data is kind of where they see they need to be kind of tapping into understanding that a little better. So oncology is a great place where actually you're capturing a lot of that information, not just the claims information, but kind of the rich clinical information in the prior authorization space, because that is really relevant information and really tries to glean the relevant pieces of information as opposed to the vast amount of the physician notes or whatever is out there. The rich clinical history associated with the person is already kind of tapped into some of those discrete valuable elements. So they're kind of putting some of these programs in which can allow you to tap into better pathways for better management, which can allow you to kind of show those predictors of certain things in the future. So we see some of those seeds of kind of activity happening. Some of them I'm sure will kind of succeed, some may not. So we want those kinds of things to fail fast and kind of try more and more of those things and kind of move on.
That's great.
One of the things I think is important, because we're talking about technology, we're talking about engaging the consumer. All of the research that I've been involved in and that I've read and seen fundamentally starts with the consumer trusting. And I think it's important to not lose sight of that, because all of these great things that we can do, the more data we want to use and consume and aggregate, it's fundamentally the consumers want to trust. And for them to trust us, and when I say us, it's not just the payer, it's the healthcare system, it's the provider side and the payer side coming together. It's doing the basics right. And if you kind of look at a Maslow's hierarchy, we've got to get the basics right first. And I have to steal your word. You said we suck. And as an industry, we do at gaining people's trust because we make mistakes on basic things. Where you can sit up here and say, as an industry, we struggle with membership. The payers right now are taking the brunt of the pain of the provider directories being wrong from CMS, but they can't be right if the providers don't give you the right information. I can't tell you if Dr. Jones is accepting patients truthfully if every time I call they say yes, or every time I send a roster they send it back saying it's right. So I just think it's real important that we can't jump. I think companies often make mistakes. They jump from where we are to a digital world, and they try and distribute all this stuff. And until you get it codified appropriately and structured in a way that's reliable and dependable to build trust, to distribute it actually destroys trust and is going to make it harder and harder for our industry to take control and accomplish our collective goal, which is better health for consumers.
That's absolutely right. No, it's well said. The basics, getting those right, are the foundation to everything, and building that experience with the consumer is going to lead to more positive interactions with them. One of the basics that we are doing in terms of enterprise-wide is the procurement process, or identifying the problem, going to market to try to find something that's going to fill solve up for that problem. As we're wrapping up here, there's some solutions that are out there that are putting the value proposition, but there's multiple applications to what they do. I was speaking to Eugene at Softheon, and some of the amazing things that they're doing around the consumer and the data analytics, that can be applied across the board through an enterprise as well as through the provider side as well. And it's one solution with multiple value propositions that are going there. And as we're closing this out, what is one company, one provider, a solution provider that you've worked with as a partner that's had multiple applications that you can think of, or that you would like to see solve a problem, not just in one function around the CEO, but also throughout the ecosystem? Scott? So kind of on the spot. Apologize for that, but there's probably 5 or 6. But
yeah, so I mean, you at UPMC, it's a little bit of a complex environment. So we, from a population health standpoint, we actually on the payer side, we've built our own population health system, and we actually partnered with. We've actually co-founded, or UPMC co-founded, the creation of Evolent, which is a company that goes in and basically sells a lot of payer-like services to provider systems, what have you. I think through that experience and through through the UPMC enterprises, which is constantly looking at and identifying and investing in companies like Health Catalyst and other companies like that have footprints and are trying to basically expand those footprints. I think that there's a lot of different companies that have the potential to help out in the capacity. I don't think anybody, frankly, that I'm aware of has the solution fully baked.
Sure.
And I think that the other problem or challenge that most payers and/or providers have is that we have, unless you're brand new startup, you have a lot of, into Ian's part, you have all these legacy systems in place today. So you don't, you need to be able to put a solution in place and/or build or wrap a solution around it that basically has the flexibility to integrate into what you have. And then you're going to have to, regardless, you're going to have to put your operational, your technology folks to work and the business folks underneath it to make sure that those processes and operational components can actually, hum and integrate with that solution. So I don't think that, there's no silver bullet from that standpoint. But I do think, going back to Ian's point, I think that we as an industry, and certainly down to the company level, we need to do a better job of making sure that we have the foundation, set in place. It's very easy to go out and see, a lot of great technologies. I've seen and heard a lot of them today. It's just here. But frankly, if the data underneath it is not working, and it's not just the payer or it's not just the provider, it's how those two work together in large part, then the experience for the consumer is going to be, subpar.
That's right. Ian, you have the luxury of having Cambia Digital Health. It's kind of a digital tool on demand type of thing. Do you often look to that to kind of see where those, to optimize the legacy programs or to get you where you need to be?
It's hard, I think. We looked within Cambia, of course, anytime we can to use our assets to leverage them. But I would tell you, I've been struggling this. I was glad you went first because I was trying to think of it.
Sorry about that.
And I would say that I see very few companies that are truly companies to help, that they're more capabilities. And I think that's one of the problems in the industry. All too often, I have companies come and they pitch their solution, and I ask them, how do you work with this other company? And, well, sometimes we're a partner, and people have pieces of the puzzle, and they're making it too hard for us to put the puzzle together, where what we need them to do is come with integrated solutions as a virtual company instead of 5 companies coming to my office, because the truth is I'm not smart enough to figure out how to put it together. And I think that is an industry-wide challenge, which is why we have to move beyond the myopic focus on competition and figure out how to create solutions by partnering across the industry. So I don't have any one company.
Oh, that's great. I'd like to use the last 10 minutes or so for question and answers to open it up. I think there's a mic up front, but the panel's been great, and we'd love to hear from you. Nick.
Now comes the hard question. Those with addictions, those with behavioral patterns that they don't want to change. How do you use data-driven solutions in an environment where you may have to constrain boundaries rather than expand them and not necessarily pay attention to customer satisfaction surveys? So there's, in light of the current opioid mortality crisis, people are expanding their boundaries rather than constricting them. Have any of you put any thought in terms of those tough to manage patients and where we need to get a little bit tougher, but allow them to come to the same conclusion that they need to take care of things themselves?
Anyone want to start that off?
That's a tough one, huh?
Yeah.
It's a tough one.
I can take a stab at it because I'm not going to directly answer your question. As the association, we kind of are not a health plan. We kind of coordinate between the various blues, right? So what we are trying to do in a data leadership space is we are trying to shine a light on opioid abuse. So we have, last year we kind of started this initiative called Health of America, where we are kind of showcasing different aspects of information and insights which can be gleaned about various aspects of public health wellness across the US. And we are trying to highlight that. So what we are also trying to do is then push that across through various channels and get that broader outreach that then can galvanize various entities in the healthcare space to do something about it, because we do see this as a huge issue, and there are various facets to it.
Yeah, I'll jump in as well. I think that Virginia is looking at substance abuse disorders right now, and some major shifts are happening in our marketplace, and we're going to need to respond to those as a plan as well as a system. And I think, I'm going to kind of answer the question with a slightly different example. Some of the best models that I've seen around the behavioral health issues that lead to ineffective outreach or that lead to disparities in healthcare outcomes gets to, I think, a redesign of our healthcare system at its core. So as a physician, I always got careful to say this in front of other physicians, so I'm in a dangerous space right now. But I think, because there's a number of my colleagues in the room, but there are things. One of the best programs that I saw was in Tennessee, and working for BlueCross BlueShield in Tennessee at the time, and we had a foundation that was supported a maternity program out in Memphis called the Blues Project. And I saw 2 cycles of over 2,000 women each go through this program. And they essentially improved clinical outcomes of the mom, decreased prematurity of the infants, almost eliminated entirely mortality of the infants, as well as got moms their GEDs and broke cycles of abuse, both physical and substance. They did it all without MDs. There's a PhD researcher who grew up in that community. And we were funding it through our foundation. And what I saw after 2 cycles, we were ready to start to scale it to a different market. To say, okay, we got a great team here. How do we take it elsewhere, right? And it was very paper and pencil kind of outreach, right? It wasn't technology. This was sort of, again, block and tackle. I saw the medical establishment at its worst actually shut this thing down because the MDs weren't involved and they had a competing research program. I'll leave it at that. And I think that's where, when you start talking about things that we've struggled with as a health system, I think we've got to think, how do we use technology, digital, as well as old boots on the ground, in a different and unique way? The MD scares somebody, right? I learned that very early in my practice years, right? My nurses would come to me, about half my patients would get better counseling from my nurses, even though I did my darndest to tell them something. They couldn't really hear it coming from me. They could hear it coming from the nurse. I think the same is true. Behavioral health, substance abuse, same thing. We've got to really redesign the way we do it and use technology to standardize, what might be a peer approach to care in the substance abuse space, and then use it so the MDs can look over it, right? The healthcare system's not saying they don't have a place, but it's a team-based approach to care that technology, I think, can support in ways that we never used to be able to do to make it scalable. So I think the future is bright on that front, but it's going to take some real innovative thinking.
Nick, I think there's one question behind you, too. Go ahead.
Yep. My question is sort of who's in charge. And, there are a million apps out there. There are a million interventions. If I have diabetes, my health plan's got an app or a DM program. Walgreens wants to take care of my diabetes. Pharma company dropping me apps. My doctor's got things. Like, who should I listen to? Who should I trust? Who's in charge?
I'm going to say I think it's part of the answer is twofold. Part of it is, who do you think is in charge of your care as a patient, right? And more often than not, I think the patient's going to say, my doctor, right? Me and my doctor, right, working together. But that said, it doesn't mean the physician is the one that's necessarily interacting. Back to my example of last, the team-based approach to care. Who best to help that patient do what they need to do and be successful? It might be a coach, might be a peer, it might be the physician, might be a nurse, might be an educator. And then the technology is going to support that based on what the patient wants. Ultimately, I think everybody else, when I look at work we're doing at Optima to try to drive patient outcomes, right? I prefer, the best model that I've found so far in my 2 years there, and some of the things we've really pushed hard on and had great success, is when Optima helps the physician's office do something, and they don't realize, the patient don't realize we were helping the physician's office get something done to help them be successful as patients working with their doctor. Does that make sense?
So I'd answer it slightly different from a blasphemy perspective. And I would say that you are. And until you recognize that and play that role, and that we enable that role, we're going to struggle in the healthcare system, whether it's with opiate abuse, whether it's with non-compliant diabetics. What I've seen, and I have personal experience with my son, who's a diabetic, and he's been that way for, 25 years now, and he's only 29. He takes control of his diabetes, and he decides which provider he's most comfortable with and who he wants to interact with and how. And it's our job collectively as an industry to enable him to do that. And if he doesn't want to do that, then it gets to, I think, your comments about how do we figure out from a propensity model, looking at the data and the analytics, what's important enough to him to try and get him there, or who of this model will have the greatest influence on him. But until we accept the fact that you are in charge, we're going to struggle.
Yeah, your son is his own medical home.
Yes.
And he is his general contractor for his home.
Yes.
Yes, I would echo that. I mean, you as an educated consumer is the key part of it, and how do we educate you as the consumer is the key aspect.
And that's getting the data to the consumer in a way that a consumer can consume it, not in these clinical terms or these esoteric terms that work for us.
Yeah. I think we have time for one more. Go ahead, please.
Right. I wanted to try and address the question about the opiate-dependent person. You know, that very, very difficult patient population, but one that really can move forward with the right system that's put in place, and that's with integration of medical and behavioral together. I think many of you probably already have systems that will identify these individuals by using your pharmacy data as being those that potentially are addicted, may have pain and other pieces. What needs to happen beyond that with your behavioral health specialist, and I assume that you have that on board, is that the contracting for the behavioral health specialist needs to be one, just like what primary care physicians have case managers to help with complicated cases. Your substance use disorder comprehensive programs need to have that case management component and be attributed to that member so that they are accountable and therefore will be doing that outreach. Also, the inclusion of peers within their provider set is very, very helpful, because it's peers that can relate to that individual on their level, their experiential level, and develop that engagement in some way. It's a very difficult case, but it's one that it does require a system. Health plans are able to do that through their contracting, through the identification, and through creating the system and the incentives within the system to manage and hold on to that patient.
Thank you. I mean, that's that granular level that we need to get down. We can sit here and talk about this and you know, overarching themes and certain examples that we have within our organizations, and I'm grateful that this panel was able to share that. But hopefully we're continuing to frame questions, ask harder questions, reach out to the marketplace to get those answers in a collaborative way, and that we're continuing to push the needle, because it does impact the lives of our plan members as well as our community. So thank you very much, everyone.
Thank you so much to this excellent panel. The next session starts at 2:05. Have a fantastic afternoon.
Whoops. I don't want to go too far.